Hi, my name is W.Porter McRoberts MD, and I am an interventional physiatrist here in Fort Lauderdale, Florida. Today I want to talk to you about degenerative disc disease and what is known as discogenic pain. It's a common etiology. We think that probably 30 to 40% of all axial pain in the back and neck may come from the actual disc or dysfunction of the disc. But today I want to explain what it is, how it affects people, what the symptoms are, and what are the newest and latest and greatest 2025-26 treatments for this problem as we get better and better at essentially needle technology, the ability for us to manage pain and also disorders within the spine becomes exponentially better in time. So very excited to present this to you, and I look forward to hearing what your comments are below, what your thoughts are. I think we're on the edge of a great advancement, not only in pain medicine, but in what we can do with minimally invasive techniques, essentially needles within the spine for discogenic pain in the cervical, thoracic, and lumbar spine. All right, here we go. So first, a little anatomy. This, of course, is the lumbar spine. It may not look like that at first, but you can see that when we turn it from this side, it looks a little more recognizable. This is the hip, or what we call the ilium, okay? Down here is where the femur would come in, right there. As we turn around, we're looking at the back, but we've taken away all the muscles, we've taken away the bone over the sacrum, and so now we can see the sacral nerves, we can see the bones here. These are the bones that make the facet joint. These are the spinous processes, you can see them there. These are what if you reach back there, you can feel them. And then the all-important disc, which is this structure right here. And so here's an intact disc in this spine. Here at L5S1, you can kind of see it from the front, what it looks like. And so when these things bulge, what they do is they come out and they press in on the spine and on the nerve. And so they entrap the nerve. You see this little bit of nerve. Here's a great picture. This is the nerve, and then the cell bodies of the nerve in this called the dorsal ganglion. So if the disc herniates, it generally herniates backwards into the canal and can injure, press on, constrict upon the exiting nerve. And that is what causes leg pain and radiculopathy, sciatica, so to speak. But what can happen, what also happens, is that the disc itself is filled with nerve fibers. And interestingly, if we look at the disc itself has minimal nerve fibers in front and significant nerve fibers behind. And so as the disc degenerates in time, and I'm going to show you some video of MRIs and x-rays, this disc starts to degenerate and lose the internal component. And the disc is essentially made of two things. That one thing, that the outside, the annulus, called the annulus fibrosus, is like the steel belts on a steel belted radial tire. And then the inside is called the nucleus pulposus, and that's kind of think of it like the jelly in a jelly donut. So the job is to separate the bones from each other, and as long as they're well separated, then it's hard to have these bones close to each other. They don't bang into each other, and there's good height and hydration. What I call tall, plump, and juicy is perfect. This is pretty good. This is pretty darn good. This is good. You can see the bone. This model is trying to show degeneration of the bone, but honestly, you wouldn't see this unless the disc itself were failing. So the stability of the spine, as you can see, is a function of not just the disc in terms of the up-down trauma that occurs, walking, etc., but then you have the facet joints, which limits the movement of the segment forward relative to the segment below it. So these facet joints on either side, you can see, they form essentially a tripod with the disc in front and the two facet joints in the back. So next I'm going to show you a little x-ray of degenerative disc disease in a human. And since we're vertical, we tend to have quite a bit of stress from the weight of our own bodies, our upper torso, on the disc. And while day after day, that's not too bad, but week after month after year of doing whatever you're doing, and really it's a balance between doing too much and doing too little, because there's pitfalls with each. But that disc, and also depending on your genetics, can start to deteriorate. And the way it does, in the first way in which it deteriorates, is little fissures occur in the actual annulus. So kind of like fissures in the wall of the tire. There's what we call lamellar fibers. These are the belts that contain the nucleus, and they are woven together, about 72 belts of these fibers wrapping around the disc, holding the nucleus, but the jelly on the inside. And as that moves, this is what happens, and they swell and they move out. That's the normal occurrence. And what happens is during the day, you start to lose and squeeze, and so the nucleus pulposus is really filled with almost like a sponge-like material, which is hydrophilic. It loves water. So as you rest and lie down, the fluids in your body redistribute, and the spine itself will actually grow in length. The disc will swell as they rehydrate overnight as you're lying down, taking the stress off, no gravity, nothing like that, and they get tall, plump, and juicy again. Normally, as you stand up in the middle or in the morning, you could actually measure your height, and surprisingly, and it depends, of course, on how old you are, but you will be taller in the morning than you are before you go to bed at night. Just because overnight, that gradual compression then squeezes the water out of the sponge, and it gets drier, and you start to compress. At night, you refill. And that process, back and forth, day after day, is what pumps in and out the nutrition of those nucleus pulposus and of the annulus and the disc itself. It's interesting, in a normal disc, there is no blood supply to the disc, which is pretty fascinating when you think about, how many things in the body require blood supply. There is blood supply to the bone above it and the bone below it. And then on either side of the disc, there's something called an end plate. And this end plate diffuses the nutrition, the fluids through as you sleep into the disc, and it reabsorbs all this, but no blood actually gets to the disc itself, which is important. Later I'll tell you about exactly why, and one of the marvels of human engineering that is pretty interesting. But nevertheless, that's why sleep for spine pain is so restorative. And I'll make another video on how to pick the right mattress, actually based on your type of back pain and problem. That'll be a subsequent video. But nevertheless, you must lay down, you must take the pressure off on a daily basis. And otherwise, you will not rehydrate. And I would say that degenerative disc disease is essentially a war between the amount of restitution, rehydration, and repair, that on one side balanced with the destruction of the disc, the wear and tear of the disc in normal daily activities. As soon as that balance starts to favor the destruction, then you start the slide towards disc degeneration. That could be anything from not enough sleep, too much wear and tear. Smoking actually impairs the passage of the fluids through the end plate, so that the disc doesn't get the restorative hydration that normally needs. So we know that smoking is highly correlated with back pain. That's probably why, because it makes the platelets really sticky in the blood, and it clogs those pores from the end plates essentially. But nevertheless, that's how degenerative disc disease occurs in the normal atraumatic. You didn't have an accident, you weren't involved in a car wreck. Why do people have degenerative disc disease? That's why. Because it's this wear and tear over years. You need tires, new tires, sometimes from an accident, but most commonly from just time and distance spent on those tires. It's the same with the disc. So early in life, we have degenerative disc disease because of traumatic events. It's rare that the genetic formulation, the making of the disc is not as good. And what I mean by that is that our genetics program the way in which we lay down collagen and the way in which we down those fibers. And so there is a quality just with bone and eyesight and everything else. Discs are also falling into that same population. Some people have stronger annulus over here. Some people have just weaker, and it's just the way they're made. So, and it's hard to know which category you fit in, but we definitely see a familial genetic component to degenerative disc disease. But the point is that young people generally have a blown disc or a disc herniation because of a traumatic event. They, slid into the base at the wrong angle. They fell off something. They had a car accident. They, started the lawnmower in a bending, twisting, and motion and super loaded the disc, and it herniated out. So what happens in a herniation of a disc, and a disc bulge and a disc herniation, we'll talk about all those different terms, but the herniation is where the nucleus squirts outside through the actual wall of the disc and then accumulates on the other side of the disc, on the outside. And that's problematic if the amount of the juice of the jelly is enough to start to compress the nerve next to it. And then you start to feel the pain down the leg. That's how you get sciatica as a young person, is that a disc herniation then presses on, or extrusion that's squirting out of the disc material starts to press on the nerve. So there's a lot of different ways that these things can go wrong and also injure you and hurt you. And so that's, it's somewhat difficult to understand, but nevertheless, it's our ability to understand precisely the why behind the disc failure and what the disc is doing when it fails in order to treat you best. And it's not just one size fits all. In fact, I think we're learning that just like the shoulder and knee, it's a very complicated structure, really built of a combination of substructures, which then form this one dynamic unit that allows the spine to move and flex and turn and twist and yet take enormous amounts of abuse over the years. So as a young person, I'm going to talk a little bit about that, but mostly what we're going to talk about is degenerative disc disease, and the more mature person, such as myself, in their 40s, 50s, 60s, maybe even 70s and 80s, like how does that work? So at first, what happens is that the disc can herniate. What that means is the squirt out, the nucleus squirts out, it forms next to the nerve, it presses on the nerve, or conversely irritates the nerve. So if it compresses the nerve, then people get sciatica, where they get pain and maybe even a numbness or a loss of sensation, which is going down the leg. And so that going down the leg is from the pressing on the nerve part. The nerve itself is designed kind of interestingly in most folks. The nerve, it's like a wire. So think of it a wire with energy and information going up towards the brain. That's sensation, how you feel your legs, your everything, your toes, everything in your body passes through these sensory nerves. But it's matched and made and fit together with a motor nerve as well. And when it comes in and out of the spine, it's the only time where the motor and the nerve, the sensory nerve, actually path. It's kind of like I-95 in Florida. There's sometimes when the north and the south are right next to each other, as it is in the spine where the hole is, the frame where it's coming out. So when a nerve is compressed, at that point, both sometimes the upbound, so the sensory part, which is on the outside of the nerve, gets affected first. But then if the compression's significant, it starts to actually compress the motor component going down to the leg. So that's where you get the weakness. And we know this one thing, we've been able to correlate when we have compression of the nerve that involves to such a degree compression of the motor component, that's the inside of the nerve, we know things are quite serious. So if you're starting to have weakness in your leg as a function of the sciatica or the disc herniation, you really actually need surgery at that point. And we know that people that go to surgery early, and this is there are about 3 spine surgeries that are really highly effective. We know that discectomy, microdiscectomy, endoscopic discectomy are highly effective at taking the pressure off the nerve and restoring strength, because we worry that as time passes, that nerve, those motor segments, the muscle segments can die because of ischemia from compression of the nerve. And ischemia is loss of blood flow and death. Just same thing with a heart attack. So you can have a nerve attack from compression of the nerve with the disc. So it's important. If you have weakness in your legs from a disc herniation, you've got to get to the surgeon and have it decompressed. And the risk of the surgery is probably far less than the risk of you losing the function of those muscles that the nerve goes to. Okay, so a few basics of how the disc is put together, etc. We know it's a pretty simple design, end plate on top. Let's talk a little bit about lumbar spine only, because it is quite a bit different, lumbar versus cervical, and then the thoracic where the rib cage is. It's kind of a blend of both, and there's some treatment considerations because of the rib cage and the lungs. So let's think about the low back, the lumbar spine, 5 discs, L1, 2, 2, 3, 3, 4, 4, 5, 5, S1. Okay, those are the 5 discs. So Even my kids say, "Dad, why not just use Fix-A-Flat?" And not just a few patients have said the same. Great idea. We're working on it. And the problem is twofold. When you have a Fix-A-Flat, you understand there's two components. There's two things in the can. One, there's the sealant, because it's pointless to blow up a tire with a hole in it or a tire that's leaking. It might get you to the next exit, but it's not going to solve the problem. So the first issue is, how do you stop the leak in the annulus? And this is the most challenging thing right now, how to do. Like, this isn't the orthobiologic, like, how do we restore the disc back to normal question. First phase is, can we get you back to normal? Second phase is, can we make it so you don't care about the pain? Third is, we can't do jack, so we just hide the pain from the brain. But first phase is, what can we do in orthobiologics or restorative medicine? So the first question we're all working on is how to seal the annulus and stop the leak. In surgery, what we do is an annular repair. So we put a couple stitches, maybe have a specific knot that then stitches and reapproximate the annulus so it comes together and actually fits together. That stitch is actually highly important in a discectomy, because reherniation is super common. It cuts it down by almost 50%. Just have that little stitch or two to close it. Anything we can do to seal the tire. You can imagine if you had a slice in your sidewall, just simply sewing it together is a step in the right direction. Even better would be injecting some type of sealant that will turn into rubber and then seal it. But even then, it's still not quite as good as having the entire steel belted radial, lamellar fibers, the cloth of the tire intact. And so we're working on ways to inject things, I can't say too much, but different products that seal the disc itself, solving the first problem, leaky disc, bad annulus. If we can do that, we don't have anything FDA approved for it yet, but that will be a huge advancement, because that just stops the progression of the loss of the nucleus. Second thing, what can we put into the disc to plump it up again? Let's say it's a slow leak, as many are. So we actually have FDA approved protein that we take from cadaver. I'll just leave it like that. And we mix it, and then we put a needle inside the disc, which is a I'll show you why, semi-dicey procedure, intradiscal injection, but safe, done in, with good visualization. But what we do is we inject the cadaver nucleus pulposus. This has been taken from people on motorcycle crashes, etc. All those donors out there, especially in South Florida, willing to readily give all their spinal fluids, etc., which is crazy to me, but nevertheless. So we take it, we morselize it, we x-ray it to death, so we kill all of the possible bacteria and viruses or whatever could be in there. And then we send it, reconstitute it with normal saline, and then inject it into the interior of the disc. The pluses are, we've shown in prospective studies, to increase disc height, reduce pain. Obviously, if you have more protein in your disc, it's going to get taller, plumper, and juicier, especially as you sleep. More sponge, more water. More water, more protective distance between those two bones. So that is a great advancement. That's available, it's FDA approved, and we do it. So then we'll get into orthobiologics. We don't have a solution right now to the Fix-A-Flat. We can add air, but we can't seal the disc yet. But there's certain products that are coming that are very likely to do just that without getting too sticky. The problem is there's things like, you may have looked up disc seal or TIS seal. These fibrin analogs and fibrin injections are useful. But one of the concerns is that, this is sticky stuff, it's glue, and you're injecting right around nerve roots. And if you start to adhere to a nerve root, that sticky stuff, as you walk, the nerve pistons in and out next to the disc by about 1.5 inches every gait cycle. So now you've tethered that nerve to the disc. It's bad news. And it's very challenging to treat. So much so that a lot of disc herniations, if they are operated on later, there's great difficulty in resecting, taking the nerve off the disc because of the scar tissue, the fibrin that's on it, that's essentially welded the disc to the nerve. So this is a complication of of doing it a late microdiscectomy or endoscopic discectomy. So injecting the fibrin into the wall of the disc, a good idea. It is a sealant. It does work. And there's a guy here who I know in the US who's been doing it for a long time, relatively safely, but nevertheless, it's not FDA approved yet. And so it would be nice to see that, but nevertheless, we need a way to protect the spine and other neural elements from adhesion or sticking onto the nerve. So here's the other question. Can we inject something like stem cell into the disc? And so a lot of work has been done on stem cell, harvesting it, taking stem cells from others, from pluripotent stem cells, from umbilical blood, from the cord, from fat, mesenchymal stem cells out of fat, from liposomal sources, actually taking it out of a bone marrow aspirate, spinning it down. And what I might add is this, in my opinion, isn't true stem cell unless you're actually getting cord blood where it's really truly pluripotent. But again, this is not FDA approved. And there's some concern also if the FDA shows up at your office and you're injecting other things not FDA approved, and they may call that into question. Does it pass the muster of malpractice? Don't know. It's malpractice, interestingly defined as are you doing something different and more dangerous compared to your peer group locally, like geographically. So if myself and 10 other guys in local Fort Lauderdale all doing it, we're practicing standard care medicine, which is kind of interesting. But nevertheless, it's so rare now, only a few people doing it. So what about your own stuff? That's autologous. That's just you. So we take it out, we don't manipulate. This is the critical definition for the FDA, minimally manipulated. So like PRP, mesenchymal cells out of your bone marrow aspirate from your hip, or conversely MFAT. So we take micronized fat and then inject it into the disc. These are all potential very good solutions, I might add. And the way in which those work is, again, it's not reestablishing disc. It's not turning back the clock by 10, 20 years. It's not doing that. What it is doing is that we know that discs that hurt are essentially have an inflammatory component to them. So, if it's getting close to the nerve, it hurts, but it's the inflammation of the nerve that hurts. Compression, as you know, like carpal tunnel, causes numbness, not necessarily pain. If it's inflammatory, the nerve is rubbing on the canal and it's starting to hurt because it's rubbing, you get inflammation, now you get pain in addition to numbness. So the inflammatory component of the leaky disc is what makes it hurt. So when we have pain, if there's a way to reduce the inflammation, and there is, and using these orthobiologics is the kind of the general catch-all, the PRP, the bone marrow aspirate, MFAT, these kinds of things. What they do is they dramatically reduce inflammation. We've actually done studies after we inject stem cell and this stuff, and we on cadavers, or we sacrifice a rabbit or a sheep or something, we look in there, and guess what? Those cells we injected are dead. But the key to that is that cellular death of some may call the immune response and the restorative response to make more, so to speak. So you need some death in order to hijack the immune system, so to speak, to build up more cells and ultimately to reduce inflammation. But we do know inflammatory mediators drop with all of these, so things hurt less. So just like my dad, who's had degeneration over the years, has never had pain. So you need degeneration plus inflammation, or degeneration plus compression of a nerve to have pain. You can go on, and he's been playing golf and tennis his whole life. He's running. He's a madman. Just up until a few years ago, and I got checked because we're going to take a trip, doing one-arm push-ups in his late 80s, maybe 90s. We'll test him. But nevertheless, reestablishing painlessness is the key. We don't necessarily have to have an intact disc in order to have a full functional life. Or we can go run. Plenty of people out there running marathons with bad discs who have no back pain. It's reducing inflammation, which then ultimately reduces pain and restores function. So orthobiologics, the ones that are approved are where we take it from you and on the same day, inject it back into you. That's FDA approved. So let's talk a little bit about that process, how that works. Okay, I don't have a needle with me, but I'm gonna show you with a pen precisely where we go and why it's important to go to someone who knows what they're doing, because there's some sensitive neural structures right next door. And I also might add, I've seen plenty of ads on the internet, and you type it into Google, stem cell, all this. I had back stem cell, I saw it on Joe Rogan. Those guys are not, I promise you, putting it into the disc. They don't have the expertise or knowledge. It took me a long time, and the other guys, people, men and women who I know who are good at this, it takes time, and you got to go to a fellowship. You have to know what you're doing. Just willy-nilly, you'll paralyze people. So I would never go to someone who's not fellowship trained to have an intradiscal injection. Be it, you got to have some expertise in this. So let me show you why. All right. At first blush, it's hard to see the disc, isn't it? Why? We've actually even cut away part of the bone, and you still can't see the disc well because of these yellow things. These yellow things are the nerves which subserve, here's your sciatic nerve, femoral nerve coming off here, serve everything that happens below your belly button. Everything from your toes to your genitals, and everything at all that works and matters to you is served by these nerves. So when you stick a needle in, you want to make sure you avoid these nerves. If you stab this nerve or inject in it or cut it with the tip of the cutting needle, you will have serious consequences. So the first step is avoid the yellow things. So you can imagine if you're going willy-nilly or someone's not using image guidance. We use digital video x-ray to do this. So we can see where the bones are, we can see the structures. Some can use ultrasound, it's a little deep for ultrasound, but nevertheless, there are keys to going through. Some of the old greats of injectionists, Camden and others, who describe techniques that have now been long proven so that we can avoid the nerves and yet get to the disc without a dramatic injury. So as you can see right here, you can see disc right there. That's disc. The nerve generally sits in the top half of the foramen, unless you have arthritis pushing it down, etc. But what you do is you walk over here and you come to the posterior lateral aspect of the disc. The cord and all the goodies are in the middle, the thecal sac and most of the nerve roots. This is the exiting nerve root. This is the dorsal root ganglion right here, that little thing. And then you slide underneath it, and then you come to the back of the disc. Very sensitive. But then you pass through it, and the consistency of the disc is something like the eraser on a pencil. So then you pass it through, and then you take it an angle from here, you take a lateral angle, and you check to make sure that the needle is dead center of the disc. That is the way in which you properly enter the disc. So you can understand that, and it's going to take it because the skin is back here. It's not centimeters, it's inches in many of them to get down and into the disc, and it depends on where it is and how superficial the disc is, how thin you are. Let me show you the neck. So in the neck and the cervical spine here, and I'll just move that. Imagine trying to get to the disc from the back. You can't do it. Plus, you got the cord, spinal cord in the way, okay? So you can't come through here. It's not possible. You will not only nick the cord, you'll make a hole in the dura, you'll have a dural leak, the fluid it's a nightmare. Don't do it. I've actually seen it done, believe it or not. But nevertheless, not smart. You come from the side, there's all these vascular Badson's plexus, all these veins and arteries. You come from this side, coming in, and you got a big artery going to your brain to be avoided. Also a lot of yellow to avoid. Look, see, from the front. What's in front of this is the esophagus and trachea. Trachea in front, then esophagus deep to it, and then you've got the disc. So what we generally do is come in from the ventral, the front side. We move these structures apart, and we put the needle down sitting right here, and then we enter the disc in the neck from the front side. That's our technique. But nevertheless, you can imagine some, nothing against family practice, super important, thank God we have them. But if some guy goes to, or a woman goes to a weekend course or a nurse practitioner, whatever, and learns, gosh, this is what I can't imagine. I mean, you cannot hold a physician responsible when you go to someone who just doesn't know what they're doing. So you got to go to someone who's fellowship trained in interventional spine, a fellowship trained physiatrist, fellowship trained in pain anesthesiologist, or a neurosurgeon. Maybe a neurologist. I know a couple neurologists are pretty damn good, but you have to have the fellowship. That is key. You can probably do a trigger point injection without it. You can probably do a few shots without the fellowship, but nevertheless, we're down deep within the spine. Do not have anyone else. All right. So we've covered orthobiologics to some degree. I won't get into nitty gritty because the what to do and the why is a little bit nuanced. There's also cost concerns. PRP is a lot less. But for example, I like this analogy. I thought, what about stem cell? I get asked that all the time. And stem cells, I say, is kind of like dropping babies into Cuba, hoping they will become capitalists. Well, here's the point. If you don't even drop them into Cuba, and I think most of these people, they just go under the skin or in the muscle and they shoot it up. And I think it reduces a little inflammation. But, that's like dropping the babies into, Fort Lauderdale and hoping they'll swim across the straits to Cuba. It's not going to happen. So go to someone who puts it where it counts. So degenerative disc disease. So let's say we get the inflammation better, etc. Things feel better. There are a few steps, and how do we know? Because back pain is challenging. I mean, how do we know it's the disc versus, say, the joint or something else? And so one of the principal tools that we use back when we were doing fusion, lumbar spine fusion for discogenic pain, which turned out to be a disaster, and hopefully no one does that anymore. But I had a lot of patients sent to me for something called the discogram. The discogram is an injection. We put the needle in the disc just like I showed you, but instead of injecting anything that would help anybody, the old way, called a pressure discogram, is a provocative discogram, is we would then inject contrast, a little antibiotics under pressure, and then we would inflate the disc. And if the patient had pain while we were applying pressure, and not too much pressure, just the right amount, then we would say that's the disc that hurts, and we'd send them off to get a fusion, and maybe 10 or 20, possibly 30% at the most would get better. And so my practice was essentially filled with people who had the fusion, and guess what? It didn't work. It worked, they're fused, but the pain didn't go away. So we started to think about different ways to do these injections. And when I say different ways, what I mean is different ways to do the discogram. So instead of provoking and injecting into the disc to cause pain, we, it's a lot more difficult to prove that the pain is from a location unless you anesthetize it. And so the concept was we would anesthetize the disc with a local anesthetic. Instead of provoking it with a lot of pressure, put it in the disc, and then inject a little local anesthetic to anesthetize those little nerve fibers, in the disc, and then have the patient stand up and walk around and see if they're better and how much better. And so what we found was people that were profoundly better. It really did prove. It's kind of like if you said to patients like, I got elbow pain, and you press on it like, oh, it hurts. Well, let's operate on the elbow. No, you could press on a normal elbow and press hard enough and it hurts. But if you have pain and you anesthetize the joint in the elbow and the pain goes away, well, it's not from your neck or from your shoulder, or it's not carpal tunnel. It's a local, whatever that local anesthetic went. And if that's painful and there's relief, you've got the perpetrator. So we started doing the anesthetic discogram, and then we started mixing in steroid because why not? And I found that half of the patients that I then sent, these are people who are ready to go to surgery. They were sent to me by the surgeon. And so about half of those folks never went to surgery because the diagnostic shot itself actually, I would say, maybe cured their pain or made it so minimal that they didn't need to have surgery. This is a long term. So I thought, my gosh, this is, and I've never written it up, I probably should, but it changed the way I thought about practicing a spinal injection because while there is risk of putting the needle and all these other things, there is risk. What is the risk of a fusion? And if I saved 50% of those people from fusion, that's a great risk reduction. Who wants to have a fusion anyway? So I started doing that. So that is actually my first step is I do the anesthetic discogram, and I numb up the disc, and I put a little steroid in. And if people have dramatic improvement, then we know we've isolated the problem. It is discogenic by definition. And then a certain portion, and more than I would ever imagine, actually stay pretty darn good. Some completely better. However, if they don't, but they have been temporarily better, we know we have the right diagnosis, but no good treatment yet. So the next step in my mind is probably orthobiologics, but there is a competitor of late. Something that I think actually does quite a good job, but it's a totally different way of thinking about degenerative and suffering from it. As I said earlier, as my dad aged, he lost disc height, but he didn't suffer, because the point is we're not going to keep the discs like they were when you were 18. It's just not going to happen. It's like gray hair. You're going to have it. It's a factor of aging. The disc will degenerate. There's no one, unless you're space traveling to Mars or whatever, who's going to not have degeneration of their disc. The key is to not have it hurt. So if we do it with orthobiologics, that's supernatural. I think the risk is super low. The only real risk is the trauma from the needle going in. But again, if you avoid the nerve, that trauma is minimized to hardly nothing. We use super skinny, thin, little filamentous needles. But if you get it in there and you can reduce the pain, then you can go on. I've had very good success with people who have inflammatory disc pain with orthobiologics. However, again, doesn't work for everybody. So where do you go? We used to go, now's the time for fusion. Now's the time to send them to the surgeon if they can't take it anymore. And a lot of folks would just even argue, don't even have surgery, because the success rates are pretty minimal. So if you've looked at some of my other videos about ablation for facet joints, the great thinkers in this field then thought, well, why not ablate the nerve that subserves the disc? And so, as I said earlier, there's some nerve that wraps around to the back end. There's also nerve in the end plate itself. And when the disc degeneration is so severe that you start to see edema or swelling or fluid in the actual bone, what we call a modic change, then we know that a good portion of the pain is from the bone itself, not even necessarily the disc anymore. And so the concept is that if we can ablate the nerve that goes to the bone, then the whole segment is essentially anesthetized, and probably long-term. There's pretty good data. It's about 5 years out, showing very minimal degradation and relief with this basivertebral nerve ablation called Intracept procedure. But it is, again, a way, and in my thinking, it's kind of a last-ditch effort way, because it is neurodestructive in a way. But nevertheless, if we can take away the pain, then people generally get better and feel better, do more, get healthier, walk more, etc. So the concept behind that is to place a needle into the bone, not the disc. And let me show you, we do the same approach in kyphoplasty, where we have a fracture, we elevate the fracture and expand the bone before we put cement in it. So it's the same general approach. But what we do is we go through something called the pedicle, which is the bony connection between the back of the spine and the front. It's hard to see because of all the neural structure, but the target is pretty easy to get to. If you get it at the right angle, as you put it in, it slides, and it goes right ultimately into the center, pretty close to the dead center of the bone. And that's where the basivertebral nerve in the center, the plexus of nerve, exists. And so we put the same type of radiofrequency probe we use in ablation for the facet nerve. We ablate the basivertebral or disc nerve in the same way. This is done, it's somewhat biologically traumatic, orthopedically traumatic, where we have to place a needle through bone. So this is not the easiest thing to do. Again, get someone who's fellowship trained before you even think about doing something like this. But we have to generally use a hammer. Same with the kyphoplasty, except the bone is soft and easy in kyphoplasty. And this bone's generally pretty hard because they're healthy people. They just had bad discs. And so we put people to sleep, at least I do. When we do it, we use general anesthesia, which imparts two things. One, great comfort for the patient while we're doing the procedure. But two, there's a bit of a pucker factor, because an awake patient is a safe patient, and an asleep patient, you really are dependent upon neuroanatomy and also radiographic anatomy, and we're dependent on an x-ray system for this, video x-ray. So we can see some, but not all. We can't see nerve, we see bones, we see shadows. So it's based on this that we're advancing the needle with a hammer, and the needle is about the size of a pencil. And we put it into the ventral, the anterior portion of the bone, and then we slide in and curve it around to the center, a little thermocouple where we heat it up, and then heat it for about 7 to 15 minutes, actually, before we change levels. The complications of this are low, luckily. It's a safe procedure carried out in knowledgeable hands who have good knowledge of the orthopedic and vascular and neuroanatomy. But nevertheless, if you get close to that pedicle, which is the roof of where that nerve is coming out, there's the pedicle right here. That's the pedicle. So if you get close to the little nerve, which is sandwiched right up to it, you will have a radicular component to your pain. So you'll have sciatica afterwards. And it's happened to me. I've had several patients with it. Luckily, everyone's gotten better. But it's one of those that it makes you pucker a little bit because you worry, God forbid you injure the nerve. And it's a known complication. So you certainly don't want to make people worse. I mean, Hippocrates would be upset for sure. And I would. And you would. So first, don't make the patient worse. But so I approach it with hope and caution, this basivertebral nerve ablation. So all of a sudden, which was essentially, we used to have epidurals and then surgery. And that was it. And everything in between didn't exist 10 years ago. And now we have this host of options that treat discogenic pain. And in time, in probably a short time, we're going to have treatments that really work on restoring the normal physiology of the disc, which caught early would probably put surgeons out of business, which is pretty amazing to me. I mean, I love surgeons. We need them. Thank God we have neurosurgeons and orthopedic spine surgeons. Some of my best friends, and they're amazing, amazing creatures. But to not need it is wonderful, and that's ultimately the aim. The real aim is staying healthy. So don't smoke, sleep enough, get good hydration. Don't sit up to sleep if you can help it, and eat well and be happy. That's discogenic pain. W.Porter McRoberts MD. That was a rather loquacious, long. I can't believe people actually watch these videos the whole time, but hopefully I kept you engaged. And if you have discogenic pain, know you have options, great options actually. It's not just suffering, because the suffering actually kills people because you don't do the stuff you should be doing. Walking, exercising, lifting, standing, twisting, turning, riding snowmobiles, swimming, all those things, they stop when you have pain and you suffer, you age in dog years. Don't do it. Thank you very much for listening. Wait a minute, I forgot. Let me show you the MRIs and stuff. Hold on. All right, here we go. I got an MRI up. This is a guy I saw earlier today. Very nice Italian gentleman, if you're watching. Super nice guy. Guess what? He's got back pain, axial back pain. What we mean by axial is not going down the legs. So first things we see here, let me grab my pointing device here. This is a normal disc. It's tall, plump, and juicy. Actually, this is a super normal disc. He's in his 60s, as I recall. You see that's light here, so it's tall, plump. That's fluid. Anything with water in it is bright. Anything with little water in it, like the annulus, not bright. Okay. This is sagittal cut, so me right down the middle, sandwich open. Here's the skin of his back, spinous processes, canal. Okay. Bone, disc, aorta, guts. Okay, but you can see tall, plump, and juicy, no bulge, perfect. Tall, plump, and juicy, little loss of the hydration, little bulge, right? So it's a little less fluid in that disc. Here's same, little bulge, little less hydration, pretty good. This one, again, I call hamburger sign, little bulge. And the reason we have the little bulge is there's been tears in the annulus, and the proteins in the disc has leaked out in the nucleus pulposus. Wow, hold on. Look at this. Horrible looking disc, horrible looking disc. It is bone contacting bone, bone contacting bone. The disc is a flat pancake, like a big guy stood on it. Looks horrible. Same thing down here. You see disc as flat as can be, bone touching bone, or almost. I'm gonna click and go side to side. As I go to side, you see a few little things. This is called a Schmorl's node, okay? There's another Schmorl's node. This is where there's a damage in the end plate. This black line is the end plate that allows the diffusion of fluid and nutrition across into the actual nucleus pulposus as we sleep. So, but then the thing we see is, look at the solid, just uniform color of gray. That's normal. This bone is normal. There's no inflammation in it, and the fluid and everything is normal, normal. You get down here, not normal. What's not normal? You have this little bit right here, this lighter area of bone. This is where there's actually fluid, edema, swelling, and all the things that hurt are in this bone right here. All the what we call inflammatory mediators associated with not just repair but also inflammation are here. Look at this entire L5 bone. It is completely covered in inflammation and fluid. And it's the same signal as the CSF here. So, I mean, similar. So it's literally a bone which is filled with blood and not pus, but blood and plasma and all those things. So then what we're going to do is we're going to go down here. I'm going to show you a different type of slice. This is called a stir. This is what suppresses any fat signal. So fat on the previous one looked bright. Now fat looks dark. And now the only thing that looks bright is fluid, protons of water. Look at all the fluid in here and in here. This is the type of degeneration that we see that hurts. It is called a modic change, M-O-D-I-C change. And Modic, when he wrote his paper, he identified that about 95% of the people who have this finding also have back pain, a high correlation to back pain. So modic change. If we see that type of, we call it type 2 modic change, we know we have inflammatory cells and fluid within the bone, which is consistent with pain. Over time, what happens, the inflammation, the fire goes out, so to speak. The inflammation goes away, and all that inflammation is then replaced with essentially fat, which is, then it has a fat signal, where it's bright on some and then bright on others, and et cetera. And you can tell the difference on certain types of ways in which we spin the protons when we make the MRI. But nevertheless, it is a high amount. So what I'm going to do for this guy, he's talked about having the basivertebral nerve, the intricept. It would be 1, 2, 3 spots to get these 2 discs. But what I'm going to do is I'm simply going to try. I want to make sure he's got some inflammation in the facet joints. There's some in the pedicles. So there's other possible sources of pain in this guy. And I want to make sure that his pain is from this and how much of it. And we'll prove it by anesthetizing the discs and the end plates and the nerves that subserve the disc. With local anesthetic, we'll use Marcaine, and we'll use a little bit of steroid, and we'll always put a little antibiotic in just in case, God forbid, we get any bugs in there. But nevertheless, that's what the plan is. As I said earlier, it's got about a 50-50 chance, in my opinion, of getting substantial months to years long relief from this. And not being a surgical candidate then. And then let's say we just have temporary relief, then probably go on and ablate the basivertebral, which is not 100% successful, mind you. It's about 70%, 65 to 70%, depending on how well you select your candidates for it. But anyway, that's what degenerative disc disease looks like, age-related degenerative disc disease. And so, if it were a big bulge, you'd see a big blip out here, or if you'd see an extrusion, as I talked about, you'd see you'd see the juice actually coming through the disc wall and deposited out there like a clot next to the nerve. And you can see where the nerves come out. Like, here's a neuroforamen, we call it. There's the nerve. There's the hole, kind of looks like a keyhole. So the nerve, if it gets compressed by the disc herniation, that's where you get the sciatic or the radiculopathy associated with the disc bulge. But again, that's like a younger person's, say younger person, like 30s, 40s. Generally, I see it in mature people as well. But nevertheless, that's the way to think of it. I'm glad I showed you the MRI, or didn't forget. All right, there we go.